Okay, good evening, everybody, and we are so glad today to have while we are celebrating the World Heart Day. Professor Cleland will give us a very interesting lecture about diuresis or natriuresis for severe congestive heart failure. Professor John Cleland is professor of cardiology, Glasgow University, and he is the founding of the European Heart Failure Journal and the Association of Heart Failure as well. And he has done lots of publications in the field of heart failure and the telemedicine, which he's interested in. And now he is the head of the clinical trials unit in Glasgow University, and as well he is the founding chairman of academic cardiology department at Ilhan University. Well, when I have some good training with him in cardiology and in clinical research. Welcome, Professor Cleland, in our day of celebrating the World Heart Day with this interesting lecture. Professor Cleland.
Well, thank you very much for that kind introduction, and hello to all my friends and colleagues in Egypt, and hope that you're enjoying somewhat warmer weather than we are here in the UK. It's only been 15 degrees today, so definitely the beginnings of autumn. So I'm been asked to talk about diuresis or natriuresis for severe congestive heart failure. I have a few disclosures in this field to mention. So what really matters, diuresis or natriuresis? This is a consensus paper from 2019 published in the European Journal of Heart Failure. And you'll see that they suggest that if the patient is diuretic naive or taking low doses of diuretic, then you should treat them with more aggressive diuretic. And then they suggest that you should measure the amount of salt in the water, in the urine, and the urine output. And over the last 5 or so years, there's been growing emphasis on the urinary sodium and that failure of to see much salt in the urine is an indicator of diuretic resistance. But the question is it really the amount of salt that you put out that matters, or the amount of urine? And you will notice that as we go on to day 2 of this patient's admission, that the emphasis switches more and more to diuresis, and that if you have achieved your maximal loop diuretic dose, then you should be thinking about adjuvant therapies. Notice at this point, SGLT2 inhibitors were not considered first-line therapy for heart failure. So been a bit of a change since 2019, but with a much greater emphasis now on salt output rather than diuresis. But is this correct? And I think the answer is no. If we look at the composition of 1 litre of edema, then it's more than 95% water. There'll be a little bit of protein, there'll be some cells, and there'll be a little bit of salt. But it is mainly water. That water will be, as it's shown on the right-hand panel, in yellow, it's mainly an increase in interstitial water. There will be a slight expansion of the plasma volume with circulatory congestion, which may get a little bit worse as you become severely congested. But it is the water in the tissues that is the big problem in patients with heart failure. That's why they have edema. That's why they're 10 or 20 kilograms too heavy. It's not the salt, it's the water. But of course, we came from the sea, and one of the reasons why we're able to live on land is that we have a very complex organ called the kidney, which is designed to maintain our internal sea. And so we must maintain the balance between salt and water. When we look at our patients with heart failure, and this is a very large American series, you can see that the optimal serum sodium for survival is the sodium that hopefully you and I are walking around with, which is around about 140 millimoles per litre. We talk about hyponatremia being less than 137 millimoles per litre, but many people are a little bit relaxed about what is hyponatremia and will even go down to 135 before they talk about hyponatremia. And you can see the mortality is doubling or even tripling as the serum sodium drops. So you've got to deal with the water excess over and above the salt excess to manage this problem. So thinking a little bit more about what is congestion and what causes congestion, I've said that it entails a lot of excess tissue water. Circulating volume is increased a little bit. It's important not to squeeze the patient very dry in the circulation because that will drop the blood pressure. And there is a thing called the plasma refill time. So you've got to give time for water to come back from the tissues, either in the lymphatic circulation or absorbed through the capillary circulation. You've got to allow time for the water to get back into the circulation where the kidneys can then deal with it, because of course the kidneys can't deal with the tissue edema, water in the tissues. Salt is increased, but it's not increased in proportion to the tissue water in most cases, and therefore sodium concentration will fall in the extracellular water, both in the plasma and in the tissues. Chloride also goes down, so we should remember that salt is sodium chloride, and chloride will often drop, and some people believe that the chloride may be even more important than the sodium, although we tend to talk about sodium more than chloride. The arterial pressure, which is the renal perfusion pressure, is usually down, especially if in these diuretic patients with biventricular failure. And the venous pressure is elevated, and therefore the net renal perfusion is really reduced. And that is one of the fundamental problems in patients with diuretic resistant edema, that they have a low net renal perfusion. And restoring that either by dropping the venous pressure or increasing the arterial pressure could be important. Plasma albumin is usually chronically low in heart failure, surprisingly chronically low, and a strong prognostic marker in patients with decompensated heart failure. The plasma albumin is often even lower, perhaps because albumin is leaking out into tissues, perhaps because the liver is congested and not synthesizing albumin. These things, it's an important part of the problem. There may be increased capillary permeability to water and salt, but also albumin, and reduced lymphatic return because, of course, the thoracic duct drains into the venous system. And if the venous pressure is high, then lymphatic return must be reduced. We also have a neuroendocrine storm going on. The natriuretic peptides increase, but they are overwhelmed as they attempt to excrete salt. So it's only once the effect of the natriuretic peptides is overwhelmed that you will start to develop salt and water retention. Arginine vasopressin increases, and that leads to the excess water retention over salt retention. You will get some increase in angiotensin and aldosterone production that try to hang on to salt. But the real problem is that low a low net renal perfusion pressure combined with the arginine vasopressin. So what's the solution? Well, the solution is obviously diuresis, get rid of the excess water, and you need to get rid of some salt along with that in order to avoid developing hypernatremia. We also need to avoid other metabolic problems like hypokalemia. The other thing that we should be doing for these patients is early institution of disease-modifying therapies, and they include SGLT2 inhibitors and mineralocorticoid receptor antagonists. And both of these may cause a diuresis and natriuresis, although it should be noticed that mineralocorticoid receptor antagonists can exacerbate hypernatremia and cause hyperkalemia. But certainly trying to get these in early to patients with uh, uh, severe congestive heart failure. So what about achieving that diuresis? The number one thing is to make sure that you give adequate doses of loop diuretics, and we see in some places people only getting 40 milligrams of furosemide and then wondering why the patient is not doing well, not diuresing well. Many of these patients will require hundreds of milligrams of furosemide for their treatment. And then we have a number of adjuvant therapies. Two loop diuretics. I've already mentioned the SGLT2 inhibitors and mineralocorticoid antagonists, which should be used routinely. We then a popular choice after that is thiazides. These tend to be more effective if you've got normal serum sodium and chloride. It goes in and out of favor, but at the moment, I think certainly I favor digoxin, especially for patients with a low blood pressure, especially if they have a tachycardia. Giving these patients digoxin can often be helpful. Important to make sure that you rapidly, fully digitalize the patient. So these patients will need 1,500 milligrams of digoxin in order to be digitalized quickly. So micrograms. Salt. Salt is probably also more effective if a patient has a low serum sodium and chloride. It has generally been given as hypertonic saline, although there is weak evidence that oral salt might be similarly effective. You'll be aware of studies of acetazolamide suggesting that intravenous acetazolamide might be helpful in this situation. In my experience, this is more helpful if the patient is alkalotic, if they have a high serum bicarbonate. And very often in that situation, you will get an enhanced diuresis, at least for a short while, with acetazolamide. Vasopressin antagonists, these are not widely available to us, but again, may be more effective if there's the patient's hyponatremic. I'll talk a little bit more about steroids in a moment. That's an unconventional approach to patients with severe resistant congestion, but I think potentially one we should be looking at much more carefully. I won't be talking too much more about ultrafiltration and devices to get rid of the water load. But there are a number of experimental devices trying to increase thoracic duct lymph flow and reduce renal venous pressure. And of course, if you have a patient with a low arterial pressure, then do think about cardiac resynchronization therapy and even mechanical assist if the patient has got as a bridge potentially to an intervention such as transplantation. So I'll mention a few trials now. We don't have time to look at them all. This is one of the trials where they looked at very aggressive diuretic therapy, the CARES trial. You can see here that they had escalating doses of furosemide with 80 milligram boluses and up to 30 milligrams per hour of furosemide, plus up to 10 milligrams per day of metolazone. And you can see with that aggressive diuretic dosing, it was pretty well as effective as ultrafiltration. And indeed, the patients were less likely to develop problems with renal dysfunction with aggressive diuresis than they were with ultrafiltration. There are still advocates for ultrafiltration out there, but I would still regard it as an experimental therapy, but we do use it occasionally for patients where nothing else is working. This is the most recent and largest and best study of thiazides in patients with congestive heart failure, looking at it as an adjunctive therapy to furosemide. And as you can see, there is a very nice reduction in body weight in those patients who have relatively normal renal function. But as the patient develops hyponatremia and a low chloride and worse renal function, then there may be resistance to the efficacy of a thiazide diuretic. So it doesn't work for everybody. This is the Diuresis study comparing dapagliflozin, which is now, of course, a class 1 indication for patients with heart failure, compared to metolazone. And showing that they have a pretty similar impact in terms of change in weight, a pretty similar impact in terms of their congestion score in the top right-hand panel. And if you look at the impact on renal function, then it looks as though there may be an advantage to dapagliflozin and less problems with hypokalemia. So what we don't have, of course, is a study investigating the effects of thiazides in addition to a combination of furosemide and SGLT2 inhibitors, which will, of course, be of considerable interest. I mentioned that we can give salt to patients with severe congestive heart failure and a lot of peripheral edema. This has generally been done by giving hypertonic saline solutions, and this is one such study. It was overall didn't show much benefit from giving hypertonic saline solution, except for those patients who had a low chloride, and of course these patients who had a low chloride also had a low serum sodium, and in those patients with hypochloremia and hyponatremia, there did seem to be a benefit of giving hypertonic saline along with the diuretic, both in terms of urine volume and, of course, urinary sodium excretion, which is what you would expect if you're giving salt. But importantly, as you can see on the right-hand side, the congestion scores improve more in the patients with a low chloride or a low sodium treated with hypertonic saline together with loop diuretic. Said I would mention steroids. There's been one recent study just published last year, the CORTA-HF study, and another one published about 10 years ago, the COPE study from China. And these show really quite interesting impacts on the diuresis, reductions in body weight, and resolution of peripheral edema. And indeed, the Chinese study even suggested that there might be a survival advantage to patients treated with glucocorticoids for severe congestive heart failure, and improve renal function as well. We should remember that it's not just the peripheral edema and the hepatic edema that's the problem, but also renal edema, and potentially there might be a benefit in terms of treating the renal edema and improving renal function with the steroids. The last study I wanted to mention was one we recently published with a vasodilator agent called Simlanod. It's a vasodilator with nitrate-like properties, and I think nitrates would do exactly the same. And you can see we infused Simlanod or placebo into these patients, and then after a 4-hour period, gave them an intravenous bolus of furosemide. And notice that the patients who were given the vasodilator had a much worse furosemide-induced diuresis than the people who were on the placebo. And I think this is due to the reduction in blood pressure with these agents. So when you give a vasodilator, you reduce the renal perfusion pressure. If you don't drop the venous pressure enough, then net renal perfusion pressure will drop. And these patients will retain water, and they'll also retain salt, and the plasma volume will go up. So vasodilators might be useful for patients in acute pulmonary edema given for 1 to maybe 3 hours at most. But in terms of the patient who is fairly comfortable at rest in a semi-recumbent position, I don't think there is a role for vasodilator therapy unless the patient has severe hypertension. So in conclusion, just to remind you of the goals of treating congestion, they are to relieve the symptoms and signs. They are to improve the patient's well-being and functional capacity. Can the patient actually get up and go to the toilet? We, of course, want to prevent relapse and improve survival. But we have to remember that it may be that short-term treatments to improve symptoms and signs might not be the same ones that improve relapse and survival. Loop diuretics may be excellent at relieving congestion, but they may do nothing, or they may even have an adverse impact on longer-term prognosis. So, and then when we're thinking of the choice of decongestive therapy beyond loop diuretics, then SGLT2 inhibitors and MRA for all patients, with a few exceptions. If the blood pressure is low or they're in rapid atrial fibrillation, of course, digoxin. If they have a low serum sodium or chloride, then think about giving the patient salt. And if vasopressin antagonists are available to you, you might also consider those. For those patients who are just water overloaded and have reasonable renal function and are not hyponatremic, think thiazides. And when the patient is alkalotic, think acetazolamide. And we look forward to future studies of steroids in this population. So, thank you.